Hello everyone, welcome to Raaonline. I'm Dr. Sujata, consultant radiologist. Our topic for today is Introduction to Basic Mammography. Before we move on to mammography, let's have a quick look on the facts about breast cancer. Breast cancer is the most commonly occurring cancer in women. On an average, every 2 minutes a woman is diagnosed with breast cancer in the United States, and about 1 in 8 women in the UK are diagnosed with breast cancer during their lifetime. The screening protocol differs in each country. For example, in UK, it is done from 50th year to 71st birthday every 3 years. And as per ACR guidelines, it is done from 40 years annually. The triple assessment is the major backbone in the breast imaging protocol. So whenever a patient comes with any symptom in the breast, the first thing which is done is a clinical examination. After clinical examination is done, the patient is subjected to imaging, which could be mammography or ultrasound depending on the age of the patient and the findings. After that, the patient is subjected to a core cut biopsy or an FNAC, and this together gives a confident diagnosis in around 95% of the patients. This is just a schematic representation of the triple assessment: the mammography images, the ultrasound images, and the biopsies which are done. Like there's the FNAC and there's the core cut biopsy. There are a lot of newer modalities. MRI is more commonly used nowadays. Tomosynthesis is commonly used. The functional imaging like spectroscopy, diffusion weighted imaging, and PET gamma imaging are also started using it now. So coming to the question, are mammograms really safe? Mammograms expose the breast to small amounts of radiation. Considering the risk versus benefit ratio, the benefits of mammography outweigh any possible harm from the radiation exposure. On an average, the total dose for a typical mammogram with 2 views for each breast is about 0.4 millisieverts. To put these doses into perspective, people in the United States are normally exposed to an average of about 3 millisieverts of radiation, background radiation every year. So if you're going to compare it to a screening mammogram, this is just the amount of a radiation a woman would get from her natural surroundings in about 7 weeks. Mammogram can be either screening or symptomatic. As with any investigation, there are limitations. So the limitations of mammograms are like women with dense breasts are more likely to get false negative results. False positive results are more common in women who are younger, have dense breasts, who have had previous breast biopsies, or who are taking estrogen. And considering the physics of mammogram, it's the same. The basis is X-ray imaging. Only difference is that the anode in the X-ray tube used for mammography is molybdenum or rhodium rather than tungsten, which is used in the general X-ray tubes. This physical change in the X-ray tube anode results in a different spectrum of X-rays that are better suited to assess the fat, the connective tissue, and the mammary tissue found in the breast. This allows for very detailed imaging of the soft tissues using this spectrum of X-ray as a source of radiation. To repeat, in a normal X-ray, the anode which we use is tungsten, and the filter which we use is aluminium, whereas in mammography, molybdenum is the commonly used anode and the filter. Sometimes rhodium is also used along with molybdenum as an anode and the filter. The base for a good mammogram is the adequate compression and the low kVp which we use. This is just a schematic representation of the mammogram where these are the X-ray beams and these are the compression paddles which are used to compress the breast so that there is adequate compression and the image is of a good quality. And coming to the types of mammogram, conventional or film mammogram is almost not done nowadays. More commonly digital 2D and digital 3D, which is nothing but the digital breast tomosynthesis, are done now. Coming to the 3D mammography or the digital mammography, as with standard 2D mammogram, each breast is compressed from 2 different angles, like one from top to bottom and one from side to side while X-rays are taken. But the difference is that the machine takes many low-dose X-rays as it moves in a small arc around the breast. Then the computer puts these images together so that you get thin slices, a series of thin slices. If you see very carefully, there is a very small lesion here, which we might have missed if just a standard 2D image was taken. So putting in a nutshell, for an adequate mammogram, there has to be an adequate compression, no motion artifacts, adequate labeling should be done, and as much as tissue as possible should be included in the mammogram image along with the correct technique. This is the MLO view and this is the craniocaudal view. So this is the mediolateral oblique or the MLO view. I'll just explain this mammogram image. This is how you mount the image. This is the right breast. This is the left breast. This is the superior quadrant. This is the inferior quadrant. The nipple. This is the retroareolar region. The pectoralis muscle. The axillary region. What you see is the axillary node, the glandular tissue and the fatty layer here. This is the skin. And this is the positioning of the patient for the MLO view. This is the craniocaudal view. The right breast, the left breast, always the lateral is, this is the lateral quadrant and this is the medial quadrant. We usually put a sticker here to show that this is the lateral quadrant, and that's how you mount it. And the compression is given from top to bottom for a craniocaudal view. So how do you know if this MLO view is adequately taken or if this is a good MLO view? First, you have to put the PNL, that is nothing but the posterior nipple line. You draw a line from the posterior nipple to the pectoralis. This is how you draw a line. You have to draw a line. So, you should always be seeing the lower edge of the pectoralis below this line. If that is there, that means it's a properly taken MLO view, and you should see this inframammary fold also there. If either of these two are not seen, then that means the entire breast is not included in the mammogram image, and you will have to repeat this examination. Coming to the craniocaudal view, this is the nipple and it should always be in profile. That means it should be in the midline. It shouldn't be facing medially or it shouldn't be facing laterally. And the next most important thing for a craniocaudal view is that you should see this retromammary space and the pectoralis muscle, this one. This has to be included in the image. So visualization of this on the CC view implies that there is no breast tissue along the chest wall which has